Welcome to the AUA's all-new monthly podcast series that focuses on leadership and business topics relevant to the entire urologic care team. Please join us each month on the Inside Tract as our subject matter experts explore various aspects of today's rapidly changing business environment. We hope you enjoyed this episode, where Dr. Jonathan Rubenstein joins host Dr. Micheal Darson to present a primer on government insurance.
Welcome to the AUA Leadership and Business Podcast Series, March 2022 episode titled Primer on Government Insurance. I'm going to be your host. My name is Dr. Micheal Darson. I'm a urologist with Arizona Urology Specialist in Scottsdale, Arizona, and the current chair of the AUA's Practice Management Committee. We are here on the AUA Leadership and Business Podcast Series to discuss government insurance, primarily focusing on Medicare. As a bit of an introduction, there are many types of government-funded insurances, including Medicare, Medicaid, State Children's Health Insurance Program, TRICARE, the Veterans Health Administration Program, and the Indian Health Service Program. Today, we're mainly going to focus on Medicare. Medicare was signed into law in 1965 to provide health insurance coverage and increased financial security for older Americans and persons with certain disabilities and illnesses. Collectively, this group was not well served by an insurance market that was mainly covered by private, employment-linked coverage. The architects of Medicare envisioned this as a first step towards achieving healthcare coverage for all. While that certainly has not panned out, Medicare currently provides health insurance for well over 60 million people, and in 2022, U.S. federal government spent over $776.2 billion. And now I'd like to introduce our guest. Today we are talking with Dr. Jonathan Rubenstein. Dr. Rubenstein is a urologist with Chesapeake Urology Associates in Baltimore, Maryland. Is both the compliance officer and medical director for coding and reimbursement for the United Urology Group, but also the chair of the Coding and Reimbursement Committee for the American Urological Association. Welcome, Dr. Rubenstein.
Oh, thanks, Dr. Darson. How are you today?
Doing very well. So our topic today is Medicare. Let's start from the beginning. Why does Medicare exist, and how did we get here?
Great. Well, the history of Medicare is always really interesting because just like anything else, especially when it's government related, can be really controversial. When looking back, it was probably over 100 years ago when the idea of either government-funded healthcare sort of came into being, and again, is political. So you look back at, Teddy Roosevelt, talked about social insurance and sickness, as part of his Progressive Party platform. And while labor unions wanted some sort of way of funding workers and their protection, the others, weren't really interested. The American Hospital Association, American Medical Association, a lot of controversy goes back and forth. And, actually, when you look at things like, FDR, when he was, signed the Social Security Act, he specifically excluded healthcare coverage from the Social Security Act because he knew it'd probably kill the bill, because everything goes back and forth. Just like anything else, political, sometimes it ends up being sort of a group gets felt to be underserved, and the emotions get behind them, and then that can lead to a push to get legislation passed. In this case, it was older Americans. When you're talking about healthcare insurance, and just as you had mentioned in the introduction, we're talking about mainly employer-based health insurance. And, citizens over the age of 65 and those with, certain illnesses were not part of the workforce. And getting a employer-based health insurance was then they were not able to achieve that. And that left people really vulnerable. And so a couple bills here or there went back and forth. Eventually, there ended up being this push. And ultimately, the group that got protected was this group over age 65, along with a couple illnesses, to help pay, what first was sort of, hospital care, but ended up evolving into overall health care. Eventually, with all the architects of Medicare, that finally was signed into law in 1965, and that is the history of Medicare as we have it. So since that time, Americans over the age of 65 and again certain illnesses are eligible for healthcare coverage, which does help with healthcare and does help with financial security, especially if you can't achieve healthcare in any other way.
Okay, so now let's talk about how Medicare works. How's it funded? What does it cover? And how is it managed?
Right. So, the main thing we have to remember is that, Medicare is really a social insurance. And so there are guaranteed benefits to whomever becomes eligible, because this comes basically from taxpayer dollars and other sources of government funding. So this is a government run system here. So when we're looking at Medicare and what it covers, the government has pretty much decided that what are the basic needs of those who are eligible for Medicare. And over time, again, went from basically it was hospital coverage. Medicare is over time split into 4 different sections of Medicare, because we realized that not only the architects realized that one thing just didn't quite cover all. So Medicare is divided right now into Medicare Part A, which basically covers hospital and other inpatient services, which was the original part of Medicare to begin with. Medicare Part B, which is mostly our outpatient services. Medicare Part C, which is the Medicare Advantage plans, and Medicare Part D, which is usually a drug program, medicine type program. So what each section, kind of has its own set of rules and the way that it's managed, and takes their money as they need to, once it's allocated, to help manage those parts of the program to help achieve health care for the Medicare beneficiaries. The way that it's actually then delivered is through what are called MACs, Medicare Administrative Contractors. So CMS, has right now it's 7 contractors covering 12 different regions, and those contractors are the ones who eventually, help manage Medicare. That's where the bills go to. That's where the Medicare, the medical directors are. That's where everything is processed, and so then there's certain private groups. We got Novitas, we got Veridian, WPS, NGS, CGS, Palmetto, and First Coast Services. Those are the groups that end up managing our Medicare on a state-by-state basis. So, once again, Medicare itself, pretty much, through our taxes and other sources of government funding, they have then a set of rules, and the set of rules determines what is covered and what's not covered. The most important part about Medicare coverage is that they state that anything that's covered by Medicare has to be reasonable and necessary for the diagnosis or treatment of illnesses or injury, or to improve the function of a malformed body member. That is the basis of what Medicare covers. And if you don't cover that aspect, or you don't meet that criteria, it's not being covered. In addition, Medicare can put together either LCDs, local coverage determinations, or NCDs, national coverage determinations, which are really a set of rules which kind of govern what is covered and what's not covered based upon medical necessity. So, for example, if there's a certain, we'll just throw out a urology procedure that is covered by an NCD or an LCD, Medicare has created a policy for what it will cover and why. And again, where a Medicare contractor at some level has laid out a certain set of rules that says you have to meet criteria 1, criteria 2, criteria 3, and exclusions are exclusion 1, exclusion 2, exclusion 3. So if you don't meet category 1, 2, and 3 and you don't have you make sure you don't mess up any of the exclusions 1, 2, and 3. If you don't meet all 6 of those things, then it's not considered medically necessary. And that's a challenge sometimes, because there's a balance between what a doctor knows is right for their patient, or believe what's right for their patient, and therefore what Medicare covers. But then again, since Medicare has, it said guaranteed benefits to the population that it covers, that's why Medicare gets say, hey, this is what we feel is medically necessary in some cases. So there are sometimes you have to meet those very specific criteria for coverage for that service for the individual patient.
Dr. Rubenstein, can you speak to the financing of Medicare?
Yeah. Well, the majority of Medicare is covered, through taxes, especially Medicare Part A. I think that the tax rate somewhere around 3%. Those who earn more than a certain level are going to have to pitch in a little bit more, but whether it comes from a payroll tax, whether it comes from U.S. Treasury, there's a set amount of money that tries to go into Medicare every year as part of the budget, and that's why every year as part of the budget they decide how much money is going to be into the Medicare system that year, and that's led to some challenges because in a way the way that physicians are paid is somewhat budget neutral. So if money is taken from one aspect of Medicare to pay for a different aspect, it's not like everything rises, but rather we can see as when we go through some of our Medicare legislations and some issues that we see as urologists, we might gain a little bit here or lose a little bit there year to year as long as it remains budget neutral. But again, this is taxpayer dollars. And the important part about this being taxpayer dollars is that when it comes to the oversight of Medicare, if somebody is doing something where they're submitting bills to Medicare, they're considered not medically necessary, the government could say that it's fraudulently billing the government. And so unlike some private insurers, it's really important that we maintain the way that we do things correctly and bill the government for the work that we do based upon their rules and based upon coverage of what patients, what's eligible to be covered for Medicare or not.
Okay. So how does Medicare pay providers?
So Medicare pays providers typically through Medicare Part D. It was actually really in 1992 when the Medicare fee schedule came into place. Before the Medicare fee schedule, Medicare providers were paid, first of all, by usual and customary rates. It's not that providers could just make up what their fees were. There's sort of a generalization of what the set fees were. And the problem is that really figured out was not sustainable. The cost of healthcare kept rising. And we realized back then that even then that they had to have some sort of control over physicians' fees. In 1975, they used what's called the Medicare Economic Index, which really limited the annual increase in physician fees by linking charges to costs over the time and operating expenses. And then between 1984 and 1991, the yearly change was really determined by legislation because physician fees were rising faster than projected. But so the Medicare fee schedule, which started in 1992, actually really put out a list of services that physicians could provide. The first year was like 7,000 or so services. Now, the way that this was figured out were some folks, mostly from Harvard, who created a system where physicians got what was called relative value units. And it was basically trying to compare the relative value of one service to another service. And so the resource-based relative value scale, the RBRVS, is the scale that's used where the RVUs, which are worked out by the work RVU, which is the amount of work that a provider uses during that service, with some practice expense RVUs, which is what the overhead costs that they should incur, plus malpractice RVUs. Those are combined to what's called a total RVU. Total RVU is then multiplied by what's called a conversion factor. And then the RVU times the conversion factor, along with some geographic index changes, spits out how much a provider receives for that service that they provide. And the important part about this system, Medicare fee schedule, is that this is really how physicians now figure out what a service is worth. And we go to the RUC, which is the Relative Value Unit Update Committee, which is run by the American Medical Association. Anytime there's a new service, the service appears to be potentially overvalued. So they can make sure that the value of that service is done appropriately year to year, and make sure that one provider's services relative to another's provider services remains as equal as they can be for the amount of work that's actually done. The issues that came into place after this Medicare fee schedule came place was that, again, costs sometimes, even with this, need to figure out year to year how much the costs rise and what physicians should be paid. And the way to make sure that, again, costs were not getting out of control, even though we had the scale in place, was that they created what's called the sustainable growth rate. So the sustainable growth rate was an attempt to control spending by setting yearly spending targets. Once again, every year, the spending seemed to outpace what was expected. And almost every year during this time, physicians were subject to a cut. And the cut was mainly by reducing the conversion factor, which was frustrating because every year, physicians and physician groups seem to have to battle to avoid a 4% cut, a 10% cut, or 20% cut, and needed legislation to even maintain their salaries year to year. As we know, the SGR was eventually replaced by MACRA in 2015, the Medicare Access and CHIP Reauthorization Act, which created our quality payment programs and our APMs. So now, since our sustainable growth rate has gone away, we're now into our system where providers are either in a quality payment program or in an APM system.
So let's move on to Medicare Oversight, Audits, and Penalties.
Okay. So, as we said before, getting reimbursed from Medicare is asking for reimbursement from the government. And back in 1863, Congress created what's called the False Claims Act. And the False Claims Act occurred because the government was sold goods and services that were not up to their standards. And one of the things they were actually sold were ill and decrepit mules. And the Congress got together and said, we need to make it illegal to fraudulently bill the government or to give us bad goods and services. And so actually that was really the basis of why we can't illegally charge Medicare, because we can actually be subject to both civil and criminal penalties for falsely submitting claims for items and services that are not reasonably necessary, trying to overbill the government. So it's really important that we know what the rules are, what the coverage is, and submit codes and bills that are medically reasonable and necessary, because we have a lot of oversight over us. And actually, medicine is probably one of the services in the United States that has the most oversight. We get reviewed by our Medicare administrative contractors, or MACs. There's recovery auditors that oversee us. And there's, of course, the Office of the Inspector General, the OIG, among others. And everyone's looking to making sure that we bill the government correctly. Our local MACs, local Medicare administrative contractors, will look through charges. They'll look for outliers and make sure that we are billing correctly. If not, they're going to ask for money back. Recovery auditors are actually financially incentivized to find things that providers are billing the government incorrectly. There's called the qui-tam provision of the False Claims Act. They actually give whistleblowers and people who find government people paid to the government, received government funds incorrectly. The people who do the whistleblowers are fined to actually get some of that money back. And of course, you don't want to mess with the OIG. So it's really important that we understand the levels of oversight of Medicare and make sure that we submit bills correctly. And so some people ask me, can this happen to urologists? We're just a small little specialty. Yeah, we've seen a lot of urologists who have been subject to investigations, mostly by who've lost money from taking money back from auditors, but also who've undergone OIG investigations. You can look it up and you can see. You type urology and OIG. There's people who've gone into either had a resolution, had to give a good amount of money back, and there's those who have been fined and those who have been subject to jail terms for illegally billing the government. So I always recommend that people understand the rules for Medicare, submit bills appropriately, and I always tell people make sure you stay out of the newspaper.
Dr. Rubenstein, that sounds like some really good advice. Do you have any insights so our audience knows, how does a recovery audit begin?
So a recovery audit really begins by an idea. I think that somebody who thinks of, okay, here's a potential area where providers could be illegally billing, or could try and find a loophole, or try and be upcoding, and every year people try and say, remember, people are financially incentivized to look for providers who are trying to either willingly or knowingly or unknowingly bill Medicare for goods or services that are either upcoded or they don't perform or incorrectly coded. So somebody really needs to think of something. And if you think of an idea, then either that company can then go to CMS or go to a MAC and say, hey, this is what we'd like to look for. Do we have your permission to do so? And then they can go and take a look around it. Other times, Medicare itself can hire an auditor to do the work for them. And finally, the OIG. The OIG is always looking for areas of potential fraud. And every year, the OIG actually puts out a work plan of things that they're looking for in ways that people can be billing the government incorrectly.
Could you give us just a quick example? So does a RAC audit come in and they look at 100 charts, and then if you're wrong on 10% of them, that's how they penalize you, or how does that work?
So, listen, a RAC audit probably gets paid per claim. For every dollar that they recover, they get a percentage of it. RAC auditors can really take as many claims as they want, as much work as they feel is necessary. The idea, of course, is that they have to figure out what's worth their time and money. Meaning, if they start an audit and they go to a group or provider and they start looking through 50 charts or 100 charts and they find 0 wrong, it may not be worth their time to continue. If they find 50 charts wrong and they're making money, they can just continue. There used to be some ideas about, hey, if you get a certain percentage right, you have to, next time you need to request fewer records and fewer records and fewer records. But ultimately, an auditor can go back as far as they want and really get as many charts as they want, as long as it's financially worth their while. There's no reason for an auditor to stop.
So the bottom line is good coding and good compliance.
Good coding, good compliance is really important. Again, the more that you bill correctly, even the first time, the more likely you're going to get paid better and paid more quickly, and the less chance you are of having to fight an audit. Listen, as I always say, it's really expensive to have to fight either an audit or just to fight denials. It just takes a lot of work out of a practice to be able to do that. So if you understand the rules and get the billing right the first time, you protect your company in the long run, you protect yourself in the long run.
So let's go to our final topic, future of Medicare, and maybe a bit about telemedicine.
Yeah. So, here's the thing. Where we are right now, most providers around the United States cheered when when MACRA came in 2015 and got rid of the SGR. And the SGR, again, they were doing every year patches. The problem with with MACRA has been that every year, again, we're sort of on a fixed budget. Although we went to a quality payment program and an APM section, The issue is that the yearly bumps that we got really didn't even keep up with inflation. So the first couple of years, Medicare would go up like 0.5%, 0.5%, 0.5%. But since that time, there's been a 0% increase across the board. And what that has led to is that, again, everyone's sort of fighting for, at this point, fewer and fewer dollars. Now, for us, people are trying to run practices. We are not even keeping up with inflation. And certainly, people in our offices are getting, their salaries gets raised every year. The cost of running a practice goes up every year, but physician reimbursement from Medicare is not going up every year. So really the challenge is how this can or can't be sustained in the future. From a personal opinion, I would love to see at least keep up with the cost of inflation. I think most providers around the country do believe that might be appropriate. Yet at the same time, if Medicare spending and healthcare spending goes up and up and up every year, they're going to have to figure out a way of really reeling in the costs in a different way that's not hurting providers. It has been really frustrating, seeing the 0% increases the last several years. So I'll be interested to see what happens, in the push from organized medicine over the next year or two, as we continue to see these problems when we're getting a 0% increase every year, yet providing the healthcare to patients goes up every year. In terms of telemedicine, at first, Medicare only paid for telemedicine in very select situations. Certain groups, certain regions, certain states were the only places that could get a telemedicine visit. When COVID occurred, starting in March of 2020, Medicare did make some exceptions, and they're mostly with telehealth, and that was for the protection of Medicare beneficiaries. As long as a public health emergency continues, it appears that the telemedicine waivers will also continue, which is great. But again, there's a long-term fix that's going to be necessary. I think most providers around the country can agree on the benefits of telemedicine. Patients don't have to drive. People can get their health care, especially those who have transportation issues. And just the fact that not every patient needs an in-person visit to get high-quality healthcare visit. Now, a long-term fix. There's a lot of legislation that's being proposed, and hopefully, we will see a long-term telemedicine resolution where we can continue providing telemedicine for Medicare beneficiaries in the future.
Excellent summary. Thank you, Dr. Rubenstein, for an excellent summary of Medicare. Both the AUA and I would like to thank the audience and Dr. Rubenstein specifically. To listen to additional podcast episodes in this series on leadership and business, please visit the AUA Inside Tract podcast at auanet.org/podcast.
Thank you for listening. For additional episodes in this podcast series, please visit the AUA Inside Tract podcast at auanet.org/podcast. If you have any research focused on leadership, business, or practice management, please consider submitting your article to AUA's peer-reviewed journal, Urology Practice. For instructions for submission, please see auajournals.org and click on Urology Practice. This journal publishes cutting-edge articles on clinical trends, challenges, and practice applications in the 4 areas of business, health policy, the specialty, and patient care.